Welcome to episode 2 of the Pro PA podcast. I'm your host, Prof G, and today's episode is part of our Clinical Medicine Brief series, where we dive into high-yield topics to help PA students, practicing PAs, and medical enthusiasts sharpen their clinical knowledge. This episode is about pneumothorax, focusing on the essentials for your Intro to Clinical Medicine course, clinical rotations, and PANCE prep. We'll cover primary spontaneous pneumothorax, secondary spontaneous pneumothorax, and tension pneumothorax. And we'll include the basics of the pathophys, who it affects, clinical presentation, workup, treatment, and some practical pearls. I like to refer to my version of pathophysiology section as Kinder Patho because it's a simplified breakdown of what's happening in the body. And remember, this episode covers the essentials, but for more comprehensive view, check out my pulmonary module playlist on YouTube on my channel, Professor G PAC. All right, let's get started. So let's start out with the primary spontaneous pneumothorax. A primary spontaneous pneumothorax, it occurs when air enters the pleural space, and this causes the lung to partially or completely collapse. And in primary spontaneous pneumothorax, the air leak typically comes from a ruptured small air-filled sacs called blebs. And these are usually located on the lung surface, most commonly in the apices. This happens in the absence of underlying lung disease. That's why it's primary spontaneous pneumothorax. Now, a pneumothorax, layman's term, of course, is a collapsed lung. And who does this typically affect? So, in a primary spontaneous pneumothorax, you typically see a tall, thin, young male patient, usually between the ages of 10 and 30 years old. And smoking also can increase the risk, even in healthy individuals. So, when I like to think of who the typical patient would be for this, someone that I can easily pull up in my mind, I like to think of the Dracula or the vampire from the movie Hotel Transylvania. If you'll recall, this Dracula is long and skinny, tall, and he likes to say the words bleb, bleb, bleb. Okay, bleb, right? We said bleb was the kinder patho behind the primary spontaneous pneumothorax. So think about that. It'll help you remember a typical patient. If you don't know what this Hotel Transylvania vampire looks like, you can either Google him or you can forget that and remember this mnemonic. You can think AIR, A-I-R. A stands for athletic build, I stands for increased height, and R stands for risky habit or smoking. So how do these patients clinically present? Typically, they present with a sudden onset of chest pain, and this chest pain can be described as sharp or pleuritic, and they also have dyspnea or trouble breathing. This pain and this problem is unilateral. Symptoms can start either at rest or on mild exertion. And a pearl that I like to share with y'all is many patients can actually describe a popping sensation just before the symptoms start. I've never actually heard that before from a patient, but I know it can happen. So how do we work up these type of patients? Well, first is first, you need to get a good history and physical exam. These are key. And you're going to look for these findings: decreased breath sounds on the affected side. You're going to listen for hyperresonance to percussion when you percuss the chest wall. And you're going to listen with your stethoscope, and you're going to hear reduced chest sounds on that side. When you do chest wall expansion, you'll also see reduced chest wall expansion on the affected side. So, typical first line test that we'll order is a chest x-ray, as in a lot of pulmonology. But this chest x-ray is going to confirm the diagnosis by showing a visible pleural line with no lung markings beyond it. And sometimes for a novice x-ray reader, it can be a little tricky or a little tough to see small pneumothoraces, but you're going to look for the lack of lung markings, and you'll look for that small little line. So not in all cases, it's going to be difficult to see some of these smaller pneumothoraces. So a pearl for this is in subtle cases where you're just not quite sure You can also consider getting expiratory films. Most of the time when we take chest x-rays, we do inspiratory films. But if you do the expiratory films, it'll actually enhance the collapse. And also nowadays, we can get CT scans if the results are equivocal. So, how do we treat primary spontaneous pneumothorax? Well, it depends how big the pneumothorax is. If it's small, and by small we mean less than 2 to 3 centimeters or 20%, these are often managed conservatively. And by conservatively, we mean oxygen therapy and observation. Oxygen accelerates reabsorption of the air. And also, we have to make sure that if we are going to go the conservative route, that the patient is asymptomatic or having very, very mild symptoms. For larger pneumothoraces, greater than 20%, or if they're very symptomatic, these will require one of two things. If they are urgent, emergent, in need of a recalibration, we can do a needle aspiration. And the definitive management, or the most common thing that we will see on testing, is a chest tube or a thoracostomy. And this is a definitive management. These patients are going to want to avoid high altitudes, diving, and flying until this resolves. So, whenever I look at my clinical medicine brief, I want to know the book med versus the street med. So, the book med means what are they going to test me on a standardized test? What is the textbook presentation? So, in the textbook, there's some suggestion that oxygen and observation really work well for stable patients and small pneumothoraces. The street med is in practice, in actual, when you're out in the clinics and ERs, treatment really varies on symptom severity and patient comfort, and more aggressive intervention is often used to prevent reoccurrence. So even though the book says you can be conservative to a certain point, a lot of times in the street, in the ERs that you'll see on rotations or out in practice, you will see that they do tend to be a little more aggressive. Um, every time I talk about pneumothoraces, I think about when I was in PA school. We actually had my first OSCE ever, so an objective structured clinical exam that I had in PA school. So I walk in, we had a standardized patient. I'm asking the questions. I start doing the physical exam, and I noticed that when I place my stethoscope on the right side of the chest, I can't hear anything. I see him take the breath, but I can't hear any breath sounds. And I go over to the left side, I can hear it. And so I was like, what is going on? Is there something really wrong with this patient? And then it clicked, boom, it clicked that he was trying to simulate the findings that he would have if he had a pneumothorax. And so I got that right, and I'll never forget it because I got tested on it in PA school. So that's our primary spontaneous pneumothorax. Under that same spontaneous pneumothorax umbrella, we have another clinical presentation called a secondary spontaneous pneumothorax. And this is similar to primary, but in secondary, it occurs in individuals with underlying lung disease. And this can be any type of lung disease, but more commonly we see it in COPD, asthma, cystic fibrosis. And with this weakened lung tissue, they are more prone to rupture, and this allows air again to leak into that pleural space. So this affects obviously patients with underlying lung disease. So most commonly, again, is COPD. Others will include asthma, cystic fibrosis, lung infections like TB, and other connective tissue disorders like Marfan syndrome. The clinical presentation is similar to primary, so you're going to have the sudden onset of chest pain and dyspnea. Symptoms are often more severe, though, and this is due to the reduced baseline lung function of these patients. So, hypoxia and hemodynamic instability are way more common in secondary spontaneous pneumothorax patients. So the workup is pretty similar. We're going to start with a thorough history physical exam, and we're going to get a chest x-ray. Chest x-ray is going to be essential for confirmation, and the findings are going to be similar to primary spontaneous pneumothorax, but they can also show some additional signs of underlying lung disease. Clinical pro for this always assess for hypoxia, as secondary spontaneous pneumothorax patients are more likely to become unstable. So treatment, again, for small ones, they'll require hospital admission for observation, oxygen, similar to small primary spontaneous. The moderate to severe or moderate to large secondary spontaneous pneumothoraces require chest tube placement. And since a secondary spontaneous is more likely to recur, it's more often that we do a definitive treatment, also called a pleurodesis, where we basically stick that pleural lining to the chest wall so that it can't collapse. And this might be needed more often in the secondary spontaneous patients. And this is to, treat the recurrence of this. And also, you need to pay attention to the underlying lung disease and try to prevent the recurrence. So, book med versus street med in this one. Guidelines are going to emphasize conservative management for stable patients, but in practice, we are much more likely to be more aggressive. Patients are more likely to be hospitalized and have closer monitoring due to their limited respiratory reserve. All right, the third topic we're going to cover on this is a tension pneumothorax. Now, with a tension pneumothorax, you should be hearing lights and sirens. And by this, I mean it is a true emergency. So the kinder patho behind a tension pneumothorax, it basically occurs when air enters the pleural space and it cannot escape. So this trapped air causes increased intrathoracic pressure, and this starts compressing the lungs, the great vessels, and even the heart, and starts pushing things over to the opposite side. And this in turn leads to impaired venous return and hemodynamic collapse. So like I mentioned, it is a true emergency. So I like to think of this as I think all of us have at one point played around with a pull floaty. So we know that pull floaties have those one-way valves we have to squeeze and blow air into them. Now imagine that one-way valve is similar to a tension pneumothorax, allowing the air to come in and enter, but it cannot escape. And so you can see that every time you take a breath in, the air fills the floaty, but it cannot escape, and this becomes trapped and pushes everything over, creating lots of problems within the thorax. So who does this often affect? We typically see this as a result from trauma. So patients from car accidents or gunshot wounds, stabbings, things like that can be affected. Also, we can cause it through mechanical ventilation or other iatrogenic causes, so us doing it, like central line placements. And these can also complicate primary spontaneous or secondary spontaneous. So the clinical presentation, again, this is lights and sirens. So we're going to see a patient in severe respiratory distress. They're going to have what's called tracheal deviation, and that is when the trachea moves from midline, and we will see it deviate away from the affected side. So if my right lung is collapsing, we'll see the trachea move towards the left side, and vice versa. We also can see hypotension from the impaired venous return and even jugular venous distension. In patients, they often appear cyanotic and in acute distress. Okay, so these are not patients that you want to sit around and ponder. They're patients you want to take action on quickly. So a mnemonic that you can think of for the key features of the tension pneumothorax are in the word thorax. Okay, so T stands for tracheal deviation. H stands for hypotension. O stands for oxygen desaturation. R stands for reduced breath sounds. A is acute distress. And X is X-ray not needed. This is a clinical diagnosis. You need to act. Okay. So a lot of times in the workup for this, we need to keep reminding ourselves we see a patient like this either on a standardized test or in the emergency room. Do not delay treatment waiting for imaging to take place. If imaging is available after they're stabilized, you can get a chest x-ray, but you need to act on your clinical diagnosis. Afterwards, after you stabilize the patient, you can get a chest x-ray. It's going to show a large pneumothorax with a mediastinal shift. How do we treat it? Well, I keep telling you, you need to take action. The action is an immediate needle decompression. And needle decompression was where we stick a large bore needle into the second intercostal space at the mid-clavicular line. And this will allow for pressure equalization in the thorax and relieve the pressure that's building within the thorax. Following this needle decompression, you need to follow up with a chest tube placement to fully evacuate the air. So, on attention pneumothorax, book med versus treat med. So, the book med is going to emphasize this step by step. You got to look for the signs and symptoms, make the diagnosis, get the chest x ray, and manage them. In the street med, in real life, it's an emergency. So, you need to follow your gut, pay attention to the signs and symptoms, and take immediate action, which is that needle decompression. And this takes precedence over any imaging or detailed assessment that you will do. All right, so now that we've covered the pneumothorax, I have a few quick review questions to review with you. So let's start with question number 1. We have a 22-year-old tall, thin male who presents with sudden onset of left-sided chest pain and shortness of breath. He denies any trauma or medical history, but admits to smoking a pack of cigarettes daily. On examination, you note decreased breath sounds on the left side and hyperresonance to percussion. Despite this, vital signs are stable, and the patient is in no acute distress. What is the most important appropriate next step in management? Option A, immediate needle decompression. B, supplemental oxygen and observation. C, chest CT to confirm the diagnosis. Or D, chest tube placement. I'll give you a second to think about it. Okay, if you said B, supplemental oxygen and observation, you are correct. This patient has a primary spontaneous pneumothorax based on his demographics. He's young, tall, thin, and a smoker, and his clinical presentation. A stable small pneumothorax, less than 2 to 3 centimeters or 20%, can often be managed with oxygen and observation. And oxygen, accelerates that reabsorption of air in the pleural space. Needle decompressions and chest tube placements are reserved for larger or symptomatic pneumothoraces. All right, question number 2. We have a 68-year-old male with a 40-year smoking history and known COPD who presents with sudden worsening of his chronic shortness of breath and right-sided chest pain. His oxygen saturation is 86% on room air. Breath sounds are diminished on the right, and chest x-ray confirms a right-sided pneumothorax. What is the most appropriate initial management? We have A, needle aspiration of the pneumothorax. B, chest tube placement and admission. C, high flow oxygen and observation. D, initiate BiPAP and monitor oxygen levels. I'll give you a second. If you said B, chest tube placement and admission, you are correct. This patient has a secondary spontaneous pneumothorax due to the history of COPD. In a secondary spontaneous pneumothorax, you are more likely to cause significant respiratory compromise, so a chest tube placement is the preferred treatment. Oxygen alone is insufficient for secondary spontaneous pneumothorax in unstable patients, and needle aspiration is typically not used in these cases. All right, the last question we have is a 35-year-old male who's brought into the ER after a motor vehicle accident. He is in severe respiratory distress. You notice some tracheal deviation to the left. He has some jugular venous distension and absent breath sounds on the right side. His blood pressure is 88/50 and his heart rate is 120 beats per minute. What is the most appropriate next step? Is it A, obtain a stat chest x-ray, B, perform immediate needle decompression, C, place chest tube at the fifth intercostal space, or D, provide 100% oxygen and observe? I'll give you some time to think about it. If you said B, perform immediate needle decompression, you are correct. This is a classic presentation of attention pneumothorax. We have tracheal deviation, absent breath sounds, hypotension, and respiratory distress. So, attention pneumothorax is a clinical diagnosis, and treatment should never be delayed for imaging. Needle decompression is the second intercostal space midclavicular line, and it is a life-saving intervention, and it relieves the pressure and restores venous return. All right, so those are the 3 questions. And to wrap things up, I want to thank you for tuning into today's episode. I hope this high-yield review of a pneumothorax was helpful and you feel more confident in recognizing and managing these conditions. For a deeper dive into pulmonary topics, please check out my pulmonary module playlist on my YouTube channel, Professor GPAC. Don't forget to follow the ProPA podcast and hit the notification bell so you never miss an episode. And as always, this is the ProPA podcast, where future pros in medicine are made. I'll catch you in the next episode.